Okay, welcome everybody to this webinar on Lyme, stealth infections and mold from Mold Illness Made Simple. I am really excited to be here today with Dr. Raj Patel from California. How are you, Raj?
I'm doing awesome.
Great.
Nice to be here.
Excellent. Are you ready for a very interesting conversation about the intricacies of Lyme disease, stealth infections and mold?
I am. It sounds fascinating. I think I'll be able to shed some light on this complex subject.
Absolutely. And I think for a lot of people, this is just such a conundrum to really get some clarity on what are the causative factors of some of these super complicated illnesses and how to be clear about finding a path forward in terms of treatment and getting towards wellness. And I hope we can shed a lot of light on these kind of disorders today and on how people can get more clear on their path forward. So thank you for joining us.
Thank you.
All right, so if we could just have the slideshow on. Okay, great. So really, so if we can go to the next slide. We're going to be presenting a lot of information today, and so what we recommend is, if possible, if you could please close or minimize other browsers and browser tabs, if at all possible, and have a pen and paper ready and some filtered water so you can write down some notes and really make the best of this time, because I think you will find that there will be some unique information presented during this next hour or hour and a half. Next, come. Okay, a lot of you who are joining this call probably know me now as the originator of the Mold Illness Made Simple course, but a very quick introduction about myself. I'm basically a physician in Australia who graduated from the University of Queensland in 1999 and was originally an intensive care doctor in Brisbane, which is in the east coast of Australia. And I've now been running a private holistic medicine practice for 10 years on the Sunshine Coast, which is called Lotus Holistic Medicine. And I also practice in Sydney, which, as you may know, is the largest city in Australia. I also do Skype consultations worldwide. I was the first doctor outside the United States to become certified in the Shoemaker protocol for chronic inflammatory response syndrome in 2014, after having experienced my own little journey with chronic inflammatory response syndrome. And I came up with a document, firstly, which was called Surviving Mold Down Under, to try to make it easier for Australian patients and practitioners to understand this illness and to be able to navigate it. I was also lucky enough to co-author the physician's consensus statement on chronic inflammatory response syndrome with some of the top docs in this field, including Dr. Ackley, Bernstein, Rappaport, McMahon, and Dr. Shoemaker himself. And as I said already, I created the Mold Illness Made Simple course last year in order to make this information as simple as possible and as understandable as possible. Thank you. Next slide. Dr. Patel, would you like to introduce yourself briefly?
Sure, yeah. I started out with a master's in physiology from Rutgers University in New Jersey, and then obtained my medical degree from University of Medicine and Dentistry. Decided to specialize in family practice. I got board certified in 1991, and subsequently started getting interested when I was down in San Diego in a more integrative approach, and started exploring functional medicine and using it in my private practice here in the Bay Area, even before the term functional medicine was coined. Worked with a lot of children with on the autistic spectrum at that time. Was very active with Defeat Autism Now. And then around 2005, I started getting interested in Lyme. I found out, similar to yourself, that I had been suffering from Lyme disease with severe fatigue and had been looking for an answer. So that kind of started my own personal journey. Completed a fellowship with Dr. Charles Ray Jones in pediatric Lyme. Became a member of ILADS, and subsequently, around 2010-11, I started getting interested in Dr. Richie Shoemaker's work with mold illness. And sure enough, I had my own little bout with mold illness too, after I recovered from Lyme. It's like the universe kind of puts you through it so you can help everyone else.
Yeah, it looks like it. Either that or you're a sucker for punishment.
But, it's good to have the insiders, track, going through all this. I got certified with Richie Shoemaker, I think it was around 2012, 2013. And I've been really working with very complicated, very sick patients who typically have one or more of these conditions, typically many of them, mold, mast cell activation disorder, viral reactivation, Lyme and tick-borne infections. And it's always challenging to really help these patients and to tease apart these different conditions and go in the right sequence that the body needs in order to help them recover.
Right, and it seems to me that having had a personal experience with these illnesses yourself, really, I imagine that's given you a much deeper understanding of these illnesses in some ways. Would you care to elaborate on that?
Oh, absolutely. I'll just share a little bit about my own journey. I started out with Lyme disease back in 2005, and went the mainstream route with antibiotics. And when oral antibiotics weren't working, went to IV antibiotics and did about 9 months of IV antibiotics, and got maybe about 20–30% better, but within 2 weeks after stopping, I relapsed again. So it really got me to think about what's going on here and what's needed. And I've explored a lot of alternative approaches, from biooxidative therapies to herbal approaches, rife machines, variety of things. And, fortunately, I was able to find my way out of this whole maze with Lyme and tick-borne infections. And what I can tell you is that I've learned how to intelligently integrate some of these different approaches. And not everyone needs to do all of those things, but sometimes when one approach is not working, having the experience with some of these other approaches can really come in handy.
Absolutely, and my personal experience was also that having experienced a degree of illness myself, and my illness was actually initially in the US when I actually got Shigella and had to take a very strong quinolone antibiotic, and then basically destroyed my gut flora, and had to work on restoring that. But one thing I found about that little experience is it gave me tremendous compassion for the suffering that patients go through. And I think that's a super important part of being a physician in this area, is being able to understand firsthand what people are going through and really try to, from firsthand experience, but also from scientific knowledge, to really be able to put together all the pieces, out of a genuine wish for them to get better. Any comments around that? And, does that resonate with you?
Sandeep, I feel that as physicians, it's our responsibility to spend as much time as is needed to accurately diagnose what's going on with each patient. And, as we've talked in the past, blood tests are not always adequate in and of themselves. And it's not just identifying all the different tick-borne infections that an individual has, but also what are some of the other inflammatory sources going on in the body. Do they have viral reactivation because of immune compromise? Are they suffering from mast cell activation disorder causing uncontrolled inflammation? And there's so many other sources of inflammation. And my experience has been that if you diagnose and identify each of these different conditions that are going on, and then approach it in a logical, reasonable sequence, most of these patients do extremely well.
Great. Thank you. Okay, well, that's a wonderful intro. Thanks, Raj. So a little bit about the idea of chronic Lyme disease. And as most of you would know, this is still considered to be a very controversial diagnosis or condition, with the majority of the infectious diseases physicians, considering that this is not a thing. This doesn't, this is not really a true condition. However, out of basically looking at Lyme disease in general, out of around 30 known species of Borrelia, so basically Borrelia is the category of bacteria which causes Lyme disease. Lyme disease is one particular or a few different subtypes, which includes Borrelia burgdorferi, Borrelia afzelii, and Borrelia guarinii. And I think now recently Borrelia mayonnae has been added as a causative factor of what we call Lyme disease. However, there are actually many other species of Borrelia as well, and one of those includes Borrelia miyamotoi, which is the causative organism of relapsing fever. And so I think that's a really important point, is to realize there is a whole group of bacteria, not just one, and they can cause a range of different presentations, not only what was classically called Lyme disease. And Lyme disease was named after Lyme, Connecticut, where this syndrome was diagnosed in 1975. Well, I think it was isolated by William Burgdorfer. However, there was another physician called Alan Steer, who I believe was credited with originally describing it. And the problem is that around 20 to 30% of people who contract acute Lyme have chronic symptoms. And there is a big controversy around what the nature of those symptoms are. And we'll explore this later in this webinar today. Thank you. Thanks, Carl. So a little bit about what are stealth infections. Well, firstly, what does the word stealth mean? And really, the word stealth suggests that these are infections that are often not easy to find. They're not easy to diagnose. Often they're not just living in the blood. They can actually be hiding away in the deep tissues or in the cells. And that's why the term stealth infections are used. And some of the important ones include, sorry, can we just go back again? Yeah, some of the important ones include tick-borne infections. And there's a whole bunch of bacteria which people can get through ticks. And this includes Babesia, Bartonella, Ehrlichia, Anaplasma, and Rickettsia. And of course, Borrelia, which we've already spoke about. But these are some of the co-infections that are often also picked up through ticks. There are also basically what we call cell wall deficient bacteria, which is a different category of bacteria, which can include Mycoplasma and Chlamydia pneumoniae, which is not the usual sexually transmitted form of chlamydia. And these are bacteria which you can get from a number of different sources. They can be from ticks, but they can also just be present in the air, and one can catch them just like you get any other cause of pneumonia. However, after one has a chest infection or a pneumonia, they can hang around in one's cells and cause a long-term infection. Would you like to talk about the viruses, Raj, maybe?
Yeah, you've got a number of different viruses that we find with our Lyme patients. We know Powassan virus is starting to become more and more well known as potentially being transmitted by a tick bite. But then we also have a variety of viruses like Epstein-Barr and HHV6 and a number of others that most of us have been exposed to during childhood. And our immune system normally will keep these under control. When the immune system starts getting compromised from Lyme or mold exposure, mold illness, or other reasons, these viruses start becoming more active. And they can be a tremendous source of inflammation, fatigue, cognitive impairment, and a variety of symptoms. So this definitely needs to be kept as doctors, we need to keep a very close lookout for these as being potential co-infections, along with some of the typical bacterial infections that we normally see.
Great, yeah, and that's a really important point you're bringing up there, Raj. And I think one of the really common ones is Epstein-Barr virus, isn't it? Which is the causative factor of, or causative organism of glandular fever. But it appears that in some people, whether they have immune compromise from Lyme-like organisms or from some other condition, Epstein-Barr virus in some cases can turn out to be a chronic infection that causes ongoing symptoms well beyond the acute infection. So that's really important to recognize. Thank you. All right, so back to the idea of CIRS, or chronic inflammatory response syndrome. And would you like to start off maybe talking about this, Raj, in your words, how you would describe the mechanism of CIRS and how
Sure.
that can happen in patients who have had a tick bite as well, maybe?
Absolutely. So basically, CIRS is a term that was coined by Dr. Shoemaker, and it stands for chronic inflammatory response syndrome. And this inflammatory response involves primarily the innate immune system. And what we know is that we see this type of an immune response both with mold illness as well as with Lyme. And what Dr. Shoemaker has done is he's identified the genetics involved. There's HLA testing available that will identify those individuals that Dr. Shoemaker terms are either Lyme susceptible or mold susceptible. And what this typically means is that these individuals have genetics that basically interferes with their immune system's ability to recognize these toxins, these biotoxins associated with Lyme and mold, and they cannot clear them from their body. They cannot create the antibodies to remove them. So in these individuals, they are more predisposed to developing illness if they happen to live in a moldy environment or they happen to get a tick bite. And what we've noticed is that in patients that are Lyme susceptible genetically, these are the individuals that have a predisposition towards developing chronic Lyme disease. When you look at the typical guidelines, IDSA says that 2 to 4 weeks of antibiotics is adequate to eradicate Lyme. And while that's true in acute Lyme disease, in someone that's been sick from Lyme, these individuals typically need far more, longer courses of antibiotics. And what I've found in my practice consistently is that those people that are Lyme susceptible need even longer courses of treatment, whereas those that are not Lyme susceptible may even recover within 6 to 8 months, even if they've had it for a number of years. So I think that that's a very useful test to run. The symptoms, let's talk a little bit about that. CIRS symptoms are associated with the typical symptoms we associate with Lyme and mold illness: fatigue, cognitive impairment, urinary frequency, bowel inflammation with leaky gut and bowel symptoms, joint pains, sleep disturbances. And these are pretty common because with both mold and Lyme, because they're triggering the same inflammatory pathways. So it becomes critical, Sandeep, for health practitioners to really look carefully, not just at the symptoms, but also the laboratory testing and any other forms of testing that they may be using to try to tease apart these similar conditions.
Right, yeah, that's very helpful. Thanks, Raj. And I guess, would you say one really important thing to understand for people is that if, let's say, someone has been bitten by a tick in the United States and develops even like a classic Lyme disease type syndrome. So a classic Lyme disease syndrome is that they would get a bullseye rash, which we call erythema migrans, and they may get a flu-like illness, except this is, it's only in a minority of cases, but that is a classic. That's a classic presentation. But if they were then to have 2 or 4 weeks of antibiotics, as you say, or even 6 weeks, some people are advocating, for treatment of that, and they still feel unwell afterwards, it's important to recognize that it could be due to the fact that they've actually got now a chronic inflammation problem, which we call CIRS. And it's actually very similar to sepsis in a sense, where in an intensive care unit, you can get something like a urinary tract infection or you can get a bacterial chest infection. And even after that's been treated by antibiotics, the patient's body can be failing. They can have kidney failure, they can have fluid in their lungs, they can have a bunch of other things because they've had a activation of their inflammatory cascade in their body. And we call that the silent fire of inflammation in the body. And going back to this diagram again, really what we've said, if you look on the right side of this page, is that instead of mounting a proper immune response against the biotoxins, which can be from the Lyme organisms, the Borrelia organisms, one gets a chaotic and ineffective inflammatory response, which creates dysfunction of a wide variety of body organs and systems. So it's a widespread bodily dysfunction syndrome. And would you also say, Raj, that then as a result of getting a Lyme-like infection, one also then can become hypersensitive to mold and chemicals, even if one originally wasn't a mold patient?
Yeah, that's a very good point. But before we go into that, I just want to kind of re-emphasize what you just said. You know, these endotoxins that are released in patients with Lyme, active Lyme infection, you know, when they're treated with antibiotics or an herbal approach, you know, whichever is chosen, you do see this massive inflammatory Herx reaction because the body is having a difficult time excreting and eliminating these endotoxins that are being released as the Lyme bacteria is being killed off. So one of the keys that I have found that increases the success rate is that as practitioners, we can do as much as we can to help the body eliminate and assist the body in eliminating these toxins, which then helps in managing the inflammation, which then helps in giving a more positive outcome in terms of the treatment. And I think later on, maybe we can spend a little bit of time elaborating on some of the different ways that we can assist the body in eliminating these biotoxins. And then to go back to your original question, you know, there's absolutely no doubt in my mind that Lyme and mold illness tend to feed off of each other. They're both associated with immune compromise. You know, mold illness does not happen just because you've got the genetics and just because you're living in a moldy place does not mean that you're going to get sick from mold illness. There is usually some other hit to the immune system. And that's one of the things that I always look for when I have a patient that has a pure mold illness or what appears to be a pure mold illness, to always stop and look a little deeper, because they've had something that caused immune compromise, which caused them to start becoming sick from mold illness. And that could be parasites, viruses, or maybe even a hidden Lyme infection that they didn't know about. And then the flip side is also true. You know, we hear stories of people that got a tick bite and who may have been carrying the Lyme bacteria and co-infections for 10, 15, 20 years and may have had maybe low-level, mild symptoms, but nothing really, anything of significance to talk about. And then something stressful happens. Maybe they get another tick bite. Maybe they're living in a moldy place and they start getting sick from the mold, or something else, something stressful, major surgery, a divorce. And then that will serve as a trigger. As the immune system gets compromised, the Lyme bacteria starts taking over and individuals start becoming more and more symptomatic. So you really have to look at the big picture here, because many times you'll see both conditions simultaneously. I know in my practice, I'd say the majority of the patients that I see have more than just Lyme or just mold.
Okay, great. So this is also really important information to realize that there's often a multifactorial nature to symptoms. So let's jump into talking a little bit about diagnosis or detection of stealth infections such as Lyme disease. And as you can see on this diagram here, there are a number of different options that patients and physicians have to start doing some testing to find out whether they could have Lyme disease or stealth infections. Would you like to maybe start off with talking a little bit about this, Raj, and some of your thoughts on the different tests?
Yeah, absolutely. First and foremost, let's, make it very clear that the current science and the current availability of Lyme testing is really not adequate to hang your hat and say without any doubt whether you have Lyme disease or not, simply based on a Lyme test. A lot of times we don't find Lyme or some of the co-infections because of some of the inadequacies of some of the testing that we unfortunately have available at this point. But with that understanding, the typical approach to testing that's recommended is to do an initial ELISA test as a screening test. And if the ELISA test for Lyme comes back positive, then you proceed with the Lyme Western blot, which is IgG and IgM testing for the antibodies. Now, one of the concerns I have with this approach is that when you're using a test like the ELISA test as an initial screening test, a good screening test should have a very high degree of sensitivity so that you don't miss anyone. Exactly. And then it may be lacking in specificity, and that's where the second test typically comes in to lock in the diagnosis. The problem with the ELISA test is that it is not that sensitive, and a lot of patients that have Lyme will come back with a negative ELISA test. So as patients and as physicians, we have to be very careful. The Lyme Western blot is specifically designed for identifying Borrelia burgdorferi. And as Dr. Gupta mentioned earlier, we have a number of different strains of Borrelia. So if you happen to get one of the European strains while you were on vacation there, for example, and then you come to the US for testing, the typical Lyme Western blot run in the US may not pick up these conditions. Then there's also Borrelia miyamotoi, which is the cause of relapsing fever. And that also typically is not picked up by a Lyme Western blot. So if you're suspecting Lyme, you need to dig deeper. These are antibody tests that are measuring the immune response to the Lyme bacteria. Now, besides the IgG, IgM testing, we have a number of other tests available. There is direct visualization of the organism under a microscope. This could be this could be like a fish test that's typically available through IGeneX laboratories that involves a radio-labeled tag that binds to the organism and then lights up when they look at the blood sample under a microscope. Another test that involves direct testing is doing PCR testing. This is looking for the DNA of the Lyme bacteria in the blood. While it's extremely highly specific, the sensitivity of PCR testing is typically about 30%. So if you're strongly suspecting Lyme, you may have to run the PCR testing on a number of different occasions to try to catch it. Moving on, viral testing. Let's talk a little bit about that. Viruses typically, as I mentioned earlier, will become more active when the immune system is compromised. So there is a cyclical pattern here, and antibody testings, if you can catch an active IgM response to the virus, can be very helpful in identifying it. High IgG titers for viruses, very controversial. My personal feeling is that sometimes high IgG titers are used to overdiagnose viruses. One of my favorite tests for viruses is the nagalase level. This is run out of Vitamin Diagnostics and is a non-specific marker for increased viral activity. And while some bacteria, such as Lyme, can cause a mild elevation in nagalase, when you see a significant elevation, it's almost always from viral reactivation.
Okay, so nagalase testing can also be a useful adjunct for looking into stealth infections, and particularly viruses.
Absolutely.
Okay, great.
And then I just want to talk a little bit about the Armin laboratories. Armin laboratories are very useful tests if you are suspecting a European strain, where if you're in the US, the local labs will not be able to identify that.
Okay,
and
great.
Galaxy Lab is an excellent laboratory for testing for Bartonella. It gets to be a little bit expensive, but if the traditional testing through some of the labs in the US does not show it, Galaxy is a very good test to resort to try to confirm the presence of a Bartonella infection.
Great. And I'll just add on the fact that culture for Lyme bacteria is now also available. And in the United States, that's run by Advanced Laboratory Services. And in Australia, it's actually available through the Australian Rickettsial Research Laboratory. So some people consider that culture is really a gold standard because it's actually looking, you know, for the Lyme organism growing on a culture plate, which is a very classical way of showing an organism. And is that something you've found to be useful, Dr. Patel, in your patients?
Yeah, many times if the Lyme Western blot does not come positive, and I'm suspecting that the individual may have, then I'll resort to either advanced laboratory culture testing or PCR.
Okay, great. And you may well be aware of the recent paper by Dr. Klinghardt and Dr. Ruggiero, which showed that that actually the use of therapeutic ultrasound to stimulate release of Lyme organisms from the deep tissues may help with the sensitivity of PCR testing, and that those particular physicians have found that if you do therapeutic ultrasound and deep tissue massage, in fact, before doing a urine PCR test for Lyme disease and co-infections through DNA Connections Laboratory in Colorado, then actually the sensitivity of the findings are actually seem to be quite good. So that's a very exciting new development, isn't it?
Yes, it is. Yes.
Yeah, so that's also something that can be looked at. Okay, great. And so for a patient who's maybe still very unwell and has seen a number of physicians and been told a number of different things, it can be a very confusing situation, and they can be extremely confused. Maybe they've been told by one physician that they have Lyme disease, and another physician has said, oh no, ignore that, you're actually got mold. How do they navigate their way through that maze of working out what's really going to be the best path for them? This is a difficult situation, isn't it? And would you like to talk a little bit about some of these testing modalities, particularly that we have in the CIRS world, that can help us to start navigating through that complex maze?
Boy, I might need a few hours for that one, Sandeep.
Exactly. Well, how about in a few minutes?
Okay, so let's talk about some of these tests here. C3A testing is positive in acute Lyme disease. So typically, if we get a patient that walks into the office and had a recent tick bite, let's say within the last few weeks, we know that the typical Western blot antibody responses take at least 6 weeks to kick in. So we'll typically run a C3A test to see if it's elevated to get some indirect indication that they have an inflammatory response that could be triggered from an active Lyme exposure. The C4A test is one of the inflammatory markers, Dr. Shoemaker has recommended in his CIRS protocol. And you've got to understand that a C4A is a non-specific cytokine immune response, and it can be seen in a variety of different conditions. So we have number 1, mold, number 2, Lyme, number 3, viral reactivation, like HHV6 will also cause elevation in C4A. Number 4, autoimmune illness will cause elevation in C4A. And number 5, lately, I'm seeing consistently elevations in C4A with my patients that have mast cell activation disorder. So those are the 5 typical conditions where we see elevations in C4A. So once you see that, you've got to tease it apart and figure out what's contributing, and you could definitely be more than one of those 5 things simultaneously. The NeuroQuant testing is, I think, a very helpful adjunctive test to support your diagnosis. We rarely use the NeuroQuant to make a diagnosis, but it will definitely give you additional support to support whatever results you've already made with your lab testing and your history. So
Right.
basically what the NeuroQuant is a quantitative volumetric measurement of different parts, different structures in the brain based on an MRI. And there are very unique specific changes that Dr. Shoemaker has identified with mold illness. Typically you see enlargement and swelling of the forebrain and the cortical gray matter. The caudate typically will atrophy. With Lyme, the right thalamus, typically is enlarged. Now, my experience with the NeuroQuant, and I've probably run well over 100 of these over the last couple of years, is that the mold changes do seem to show up pretty consistently in our mold patients. However, in my patients with Lyme, I think I've only had maybe 1 or 2 out of a number of Lyme patients that have run this test where the Lyme changes don't seem to show up that consistently at all. And then lastly, the HLA testing that I've referred to earlier is going to give you an idea whether your immune system is impaired in its ability to excrete biotoxins associated with Lyme or mold.
Right. And so would you say that that test would provide some, some helpful data for someone who's still chronically unwell and teasing their way through whether they could have Lyme disease or other stealth infections versus simply a mold-related CIRS? Could that give them a little bit of clarity?
Yeah, absolutely, Sandeep. And this is one thing I really want to bring up, is that if you are one of these patients that have only a Lyme susceptible genotype, 1 or 2 genotypes.
That includes like the 15-6-51 and the 16.
No, that's a Lyme susceptible one.
Oh, sorry, which one did you?
Mold susceptible
Oh,
one.
sorry, mold susceptible one. So 7-2-52A or one of those.
7-3-53 and 7-2-52A. Yeah. So if you have 1 or 2 mold susceptible genes and no Lyme susceptible genes and no multi-susceptible genes, you're one of the lucky ones, because your Lyme disease should be fairly easy to eradicate, because you're going to be able to excrete those Lyme endotoxins fairly easily and in a normal fashion. When I see patients like these in my practice that have been around the block being treated with antibiotics or herbs for a long time and they're not getting well, almost always, 9 times out of 10, these individuals have mold illness, and it hasn't been identified. And the minute we get them out of the moldy environment and start treating their Lyme, they start responding very rapidly.
Okay, so that's a huge, it's a huge thing to look for if you've been diagnosed with chronic Lyme and you're not getting improvement. It's super important to be aware, and I think most of the listeners of this call will already be aware of mold as an extremely important factor in their health. But I guess you're saying that if they're really not responding to Lyme treatment and chronic antibiotics, then that's a must, to look into their house and to look into whether they are in a water damaged building, and maybe to start looking at the possibility of ERMI testing and so on. Would you like to talk about that a little bit?
I want to share a story of a patient that I inherited about 1.5 years ago, who had gone through at least 10 to 15 different Lyme doctors and had been treated very aggressively with a variety of different antibiotics, including IV antibiotics, and who was basically bedbound and very non-functional. And as we started evaluating her, we found a big mold component. And she was so hyper-reactive to moldy environments that once we got her into a safe environment, and that took a good 6 to 8 months for her to find a living space that she was not reacting to because she was so hyperreactive. If she had any family members that would come in and they were wearing clothes where they had been in a moldy home and they came in, she would start reacting to the clothes. I mean, it was really bad. And people would typically have to change their clothes before they went into her apartment. And fortunately, I'm happy to say she's doing much, much better now. Once we eliminated the mold exposure completely, we've made a huge amount of progress in going after the residual Lyme infections that were still there. And she's currently about maybe 30 to 40% improved, and we're now looking at starting to do some repair work to start reversing some of the damage that's been left behind by the mold and the Lyme.
Okay, great. And so I guess what you're saying overall is that we need to always have our eye out for other conditions. It's important not to be tunnel vision as physicians and as patients, to keep our mind open to the possibility of other factors, such as mold and such as viruses and other things, as you say. So that's a really, really interesting case that you bring up there. So let's jump into talking a little bit about what could be some other clues. And as we've already said, there's a huge amount of symptom crossover between these different disorders, and often just hearing a patient's symptoms may actually not be able to give you the answer between whether they're suffering from Lyme disease and co-infection versus mold illness or CIRS due to mold. Let's talk a little bit about some of these clues that might point us in the direction of exploring one area more than another specifically. Obviously, a very obvious thing with mold illness is going to be if they tell you that their building that they live in is moldy, or that they've got musty smells, or that they feel worse in certain buildings. That's going to be a huge pointer towards the fact that mold is playing a major part in their illness. And I actually consider that one of the most suggestive things is that the fact that if people feel better in certain buildings versus other buildings, that's even more suggestive than just the fact that they're living in a moldy building. Any thoughts about that specifically?
Yeah, I completely agree with you. It's one of the first questions I always ask patients where they've had mold exposure, is that when you go into a moldy building, and this could be libraries, used bookstores, consignment stores, even places like Orchard and Home Depot, which typically will carry moldy lumber. If these individuals become symptomatic with headaches or lightheadedness or fatigue or brain fog, that becomes a very reliable indicator that they do have mold illness. Other symptoms that tend to point towards mold rather than Lyme, because like I said, the symptoms are so similar because the same inflammatory pathways are triggered. Our mold patients tend to have a higher incidence of frequent urination, increased thirst, developing static shock where you get zapped by a car handle or a doorknob frequently. These typically we tend to see more in our mold patients. Our Lyme patients, on the other hand, if they have extreme anxiety, you would suspect a Bartonella infection. If they're having
So moving on to this diagram a little bit. So if we look at the right corner here, we're mentioning anxiety, as you say. And would you say pseudo seizures? I like the spelling there, by the way.
Yeah, yeah. Pseudo seizures is this kind of almost like blanking out. And the person is not aware of their surroundings, and then maybe a few seconds or 30, 60 seconds later, they come back. This can be fairly common in severe Bartonella infections. The rash, the striae, which is a hyperpigmented purplish type of a rash that looks like stretch marks. Sometimes we'll see that in our Bartonella patients. This sore soles. One of my patients described it like the sensation of fireworks, tingling under her feet when she first wakes up in the morning. And I thought that was just a beautiful description of what it feels like.
Yeah, it sounds great, doesn't it?
And then lymphadenopathy, which is basically enlarged lymph nodes, typically, under the armpits or in the neck, which is very common with Bartonella infection also.
Okay, great. And that's a really important co-infection to be aware of, isn't it? Because it can cause terrible psychiatric symptoms. And some of the most severe psychiatric patients I've had with anxiety disorders and even psychosis had Bartonella infection underlying it. So that's an extremely important one, and it can make people feel extremely unwell. So moving on to the bottom left corner of this diagram and talking about Borrelia, which, as we mentioned before, is the group of bacteria that includes the Lyme disease bacteria. If one gets an EM rash or an erythema migrans rash, that looks like a bullet or a target sort of rash. So it's a red rash that often has a ring and it has a central red part to it. And if you're not familiar with that, just go and Google erythema migrans rash and put it in Google Images, and you'll see what they actually can have different appearance. It's not always one appearance. There is a few variations, but that's very classic for a Borrelia infection. Also, if one gets migrating joint pain, so for instance, joint pains that are in one joint that then move to another, that can be quite suspicious for a Borrelia infection. And if there's a certain cyclic nature to the symptoms that come and go every 4 weeks. So for instance, some women find that a lot of the symptoms are related to their menstrual cycle. That also can be more suggestive that a Borrelia infection is at play. Anything you'd like to add to that at all, Dr. Patel?
Yeah, you pretty much summarized it well. The only other thing I would add is that many of our mold patients will sometimes feel better when they're not in a moldy environment, whereas our Lyme patients feel bad all the time.
Right. Yeah, that's a really important one. And so if a Lyme patient, if someone was going to go camping, for instance, and they were, their main problem was Lyme disease, you wouldn't expect them to feel any different. But if they were a real mold patient, you would expect there would be at least some improvement. So that's really important. I'm just going to very quickly touch on these other ones just to speed up a little bit here, Dr. Patel. So we've already talked about viruses in the top left corner. If one has a high nagalase or low lymphocytes or even high lymphocytes on their blood tests, that can be indicative of a chronic viral infection. There is a test called adenosine, which can sometimes be indicative, and one can also have markers of low methylation, which can include a low level of SAM, or SAM-E, which is S-adenosylmethionine, or one could have a high homocysteine. These things also tend to indicate there's the possibility, and they're not definite, but they're indicators that chronic viral infection could be a problem. And then lastly, in the top right-hand corner, if one was to have Ehrlichia or Anaplasma infection, which is another, I guess, a little bit more rare type of tick-borne infection, looking for low white blood cell counts and low platelets is very important. Also, elevated liver function tests could indicate Ehrlichia or Anaplasma, or also Epstein-Barr virus. And knife-like headaches can be a sign of Ehrlichia and Anaplasma or Bartonella, actually. So look, these are some clues that may be helpful. It's very important to realize they're not diagnostic, but they're just indicators. So I'd like you to talk a little bit about the serial C4A test, Dr. Patel, if you would. I've heard you talk about this in previous interviews, and I think this is quite fascinating. It's something that's probably mainly available only to patients in the United States at this point, but would you mind talking about the serial C4A test?
Yeah, absolutely. I kind of developed this sequence out of a need to be able to come up with a fairly solid, strong diagnosis of mold illness. The problem with mold illness is that you have a series of symptoms, but you can see those same symptoms as you've heard today from Lyme also. And there is no simple single blood test to prove that someone has mold illness. There is urine mycotoxin testing, but it's not specific for environmental mold. Food, many times leftovers or fermented foods, will carry mycotoxins that end up showing on the urine mycotoxin testing. And then the other test I see sometimes is IgG. testing for different species of mold. Now, this is a test documenting an allergic response. And again, is by no means indicative of mold illness, because mold illness is an inflammatory response. So to try to come up with a solid diagnosis that would be a reliable indicator and also stand up in a legal defense that an individual may need, I started doing inflammatory markers like C4A, TGF-beta1, and MMP9, and doing a series of 3 sets of these. We'll do an initial baseline, and then we'll put the patient preferably in a mold-free environment and give them 4 weeks of cholestyramine, typically 3 to 4 times a day. And at the end of that 4-week period, while they're still on cholestyramine, we'll repeat the markers again. And what we would expect to see if that inflammation is from mold to at least a certain extent is you would expect those markers to come down, because the cholestyramine is pulling these mold toxins out of the body. Now, after the second set of labs are done, we have the patient stop the cholestyramine, go back into their water-damaged home for either 1 day or for 5 days. And during that time, they do not take any cholestyramine. And then we repeat the markers again. Now, if they truly have mold illness, you will see a spike in these inflammatory markers, which tells you that they are reacting, they're having an inflammatory response to the water-damaged home. So now you have 2 pieces of data. You see a drop in inflammatory markers with cholestyramine documenting the presence of mold illness, and then you see a spike in the inflammatory markers when they go back and do a provocative challenge to their toxic home environment. And then that documents that building is making them sick.
Right,
Now,
so you could say, sorry, keep going.
Yeah, can I just add one thing? I know that Quest Labs, a lot of the branches of Quest Labs is not running the C4A in the US. Some branches still are, fortunately, so you can try investigating that if you're a patient. The TGF and the MMP9 and then the visual contrast sensitivity test, all 3 of those can also be used in addition if the C4A is not available, and you will see similar changes.
Right, and I think some people are using other collection services to have the blood sent directly to National Jewish Laboratories in some cases. And have you had patients who have had success with that in your area?
Yeah, if you talk to, I think, FedEx, they have ways of keeping the samples cold below the indicated temperature without the use of dry ice. So it does get a little expensive, but if there's a medical practice that's looking for this, I'd encourage them to investigate that and then pool maybe once a week or once every 2 weeks, have all the patients come in and do the testing at the same time.
Okay, yeah, that should make it a lot easier for people. And so just going back to the serial C4A test, it seems like this is a truly functional test of whether a water damaged building is actually causing the inflammation. And that can sometimes be the problem with CIRS, isn't it? That one can have elevated C4A and TGF-beta1 and other markers, but it's not, and one can have an elevated ERMI as well, but it's not 100% clear whether that's the causation. And this helps to establish that.
Exactly. So when you see elevated CIRS markers like C4A, TGF, MMP9, what you really want to do is tease it apart and figure out what is contributing to it. So once you've gone through these steps to identify whether there is a presence of mold illness or not, you may still be left with a marginally elevated C4A. Maybe it's come down halfway, but it's still high. So then you have to start asking yourself, okay, besides mold, what else is causing my inflammatory markers to go up? And this is where you start looking for things like mast cell activation disorder, or if there's a big viral component. If your nagalase marker is elevated, it may be worthwhile to maybe use some low-dose antivirals along with glutathione topical and see if the markers come down even more.
Ah, okay. So that's another little trick. Okay, excellent. Thank you. All right, so let's start jumping into treatment a little bit. So let's say we have a person out there who's been given a diagnosis of both Lyme disease and co-infections and mold. How do they know what treatments are going to be most effective for them, and how do they know where to start? Would you like to talk a little bit about that, Dr. Patel?
Yeah, absolutely. First and foremost, okay, you have to eliminate the mold exposure. This is the absolute hardest step. And some patients sometimes struggle for, 3 months, 6 months and longer trying to find a safe sanctuary that they can live in. My experience has been that if you have mold illness and Lyme and you do not eliminate the mold exposure, it's a very uphill battle trying to eradicate the mold. And most of my patients do not meet with success in those situations. If they are able to find a mold-free environment, then the response to the Lyme becomes a lot faster, a lot easier, and they recover much, much faster.
Okay, great. So that really needs to be step one, if at all possible.
Yeah. So that kind of takes us to the next slide here. First and foremost, you really want to make sure that if you have mold illness, you are refraining from mold exposure. Now, this involves not just having a safe sanctuary at home, but also making sure that your workplace is safe and that you're not being exposed to mold there. And then let's take this a little step further. You're not going to be happy to hear this, but every time you walk into a store, any public building, whether it's shopping, Whole Foods or a friend's house or a library or a movie theater or a restaurant, you've got to realize that 80 to 90% of these public buildings have some degree of mold. And the nature of mold illness is that you do become hyperreactive with time. So many times it's not unusual for me to put my patients, if they're very sick from mold illness, under a modified house arrest so that we can get them well. So that's the first step. The next step we look for is mast cell activation disorder. We're starting to see this more and more. And basically, very briefly, what this is a exaggerated histamine response that's triggered by fermented foods and foods that have been left over sitting in the refrigerator for a few days or overnight. It starts to grow mold, and these individuals have exaggerated inflammatory histamine response. That inflammation will also put a wrench in your Lyme treatment if you don't address it and bring it under control. Following this, we go on to their testing, and we look for things like PKU issues.
Or pyroluria, really, I guess.
Yeah,
I think that's what's meant there was the HPL.
Yeah, that's the wrong spelling there.
Yeah, pyroluria would be a really important thing.
Cryptopyroluria.
Yeah, that's right.
So if they have KPU issues, we'll support that condition with nutrients to get their immune system functioning a little better. If they have methylation cycle impairments, we'll try to support those areas. And then from there, we go on to look for viruses. Now, typically, there's this layering that happens where the body prioritizes multiple insults. And a good analogy that's been used in the past at some of the Lyme seminars is that if you were in a dark alley and you were being jumped by 5 ninjas, you're going to prioritize and attack the one that's the most immediate threat. Well, your body does the same thing. So if it's got viruses and parasites and Lyme infections and number of other conditions, you need to prioritize. So there is a general sequence that applies to most people, but there are a lot of individual variations. But in general, what we find is that the viruses are at the top and need to be addressed first. Then come parasites, then come Babesia and Bartonella, then comes Ehrlichia, Anaplasma, and Lyme. And then from there, we go on to stealth infections like Chlamydia pneumonia and Mycoplasma pneumonia. Now, like I said, usually that's the order that seems to work the best. And once the infections are completely gone, then we go on to eradicating MARCoNS and then hopefully get the patient on VIP.
Mm-hmm. Okay, great. Thank you. So that's a really interesting bit of information there about what order of treatment may be helpful as per your experience. Would you like to talk a little bit about what sort of supportive treatment might also be helpful as well in terms of diet and supplements?
Absolutely, Sandeep. And I think this is one of the key, this is one of the important keys that helps increase your success is to manage inflammation and to manage the elimination of these toxins as they're being addressed. So diet is very important because most individuals with Lyme or mold will have a tremendous amount of gut inflammation, and they have a leaky gut and they have carbohydrate intolerance. So getting them on an anti-inflammatory diet, getting them off of gluten, off dairy, and off all sugars is absolutely crucial. A lot of these patients also cannot tolerate a lot of complex carbohydrates. So we try to have them minimize. You don't have to eliminate it completely, but most situations, if you can reduce the total carbohydrate load, that can help a lot. So what can you eat? A lot of clean organic meats, seafood, tons and tons of vegetables, salads are fine, nuts, beans, lentils, and small amounts of fresh fruit, typically 2 or 3 servings a day. So that's the diet piece. Supplements can be very helpful. If someone's going to use antibiotics, especially probiotics are absolutely crucial. Vitamin D levels are typically low, and if you have a big viral component, vitamin D supplementation can help, and also something I've talked about previously, narrowband ultraviolet B light box can be also very helpful. Glutathione levels are frequently depleted, especially if you have a viral component. So taking either N-acetylcysteine or doing transdermal glutathione can be very helpful. And this can be typically made by a compounding pharmacy. Typical dose is about 250 milligrams per milliliter, and we typically start our patients out with about half a milliliter once a day and then gradually ramp it up if required. Anti-inflammatories, short-term can be very helpful. Curcumin is great. Fish oil can be helpful. And even other things like Lypernol. A favorite product that we use in my office is Inflammablocks. So you've got a number of options there. Elimination. This is a huge piece. Once you start killing the organisms, you've got to do anything and everything you can to open up the exit doors and keep them open. The more you do this, the faster you'll be able to kill the bugs. It's a balance act. Look at it as step 1 and step 2. Step 1 is killing the bugs, and as you kill them, those endotoxins end up in the lymphatic system and in the bloodstream. Now your body has to get rid of it, so you got to support elimination. So this is where dry skin brushing can help in getting the lymphatic system moving. Ionic foot baths, we don't know how they work, but they do. A lot of my patients consistently report significant improvements. My theory is that they help open up the meridians in Chinese medicine that typically go into the feet. You could do this about 20 to 30 minutes 3 times a week. Epsom salt baking soda baths can be helpful as long as you are not sulfur intolerant. You could do this every day. Typical recipe is about 3 cups of Epsom salt, 1 cup of baking soda, and you soak for about 20 to 30 minutes. Methylation we've already talked about. Supporting the microbiome is critical to helping manage inflammation. So taking probiotics, and if you don't have mast cell activation disorder, consuming fermented foods on a regular basis can be very helpful. And then lastly, making sure that you get adequate sleep, managing stress, and the biggest one is exercise. Exercise, typically I recommend for my patients about 20 to 30 minutes of walking twice a day to get the lymphatic system moving. If you're under a lot of stress, getting into meditation, Tai Chi, yoga can be extremely, extremely helpful. If you feel that you may have some major issues that may be behind the Lyme disease, working with a therapist or doing some of your own inner journey work can be very helpful. And lastly, making sure you get adequate sleep to help your body recover and heal. So these are just some of the highlights.
Great. So we're really talking about a really holistic program here. aren't we, in order for these people to get well, especially if they've got a complex condition which is multifactorial. Really what you're saying is having an approach that that deals with and addresses almost all aspects of your illness and of your being is very, very important. And so we've called it the Patel protocol here, where you've got a slightly different order where you're focusing on removing from water damaged buildings, using some binders, and then moving up to stealth infection, eradication, MARCoNS, and VIP. And I'll just also briefly touch on the standard Shoemaker protocol, which also does include a number of different steps, such as using things like Minorin nasal spray and losartan and so on to adjust and normalize inflammatory markers. So in your case, you found that those ones can in some case be skipped safely. Is that what you found, Dr. Patel?
Yeah. What I find is that, most of this stuff we've already talked about is that, get out of the moldy environment, eliminate mold exposure, go after the infections. If you have identified all of the chronic infections that you have, parasites, viruses, different stealth infections, you will find that your inflammatory markers, C4A, TGF, MMP9, they all come down. Not only within the normal range, but actually in the low end of the normal range. Right. And once you've done that, then you go after the MARCoNS and you go on VIP. I think Dr. Shoemaker has done an amazing job coming up with the Shoemaker protocol. But what I have found is that rather than artificially suppressing these inflammatory markers with losartan and high-dose fish oil, why not find the cause of it? If your inflammatory markers are still high and you think you've gotten rid of the Lyme, you need to look again. There are some other infections or some other sources of inflammation that you've missed. And once you've identified them, you will consistently see these inflammatory markers coming down dramatically, which then opens the door for you to go on VIP successfully. Now, one thing I'd also like to add right now is that when you do the VIP, keep staying away from mold, because until your MSH levels climb up into the mid-30s range or higher, you're still going to be reacting to moldy environments. And, taking cholestyramine 2-3 times a day can help, but I find in most situations, the success rate is much higher with VIP if you continue staying out of moldy environments while you're on it and then ramp up the dose slowly, typically by 1 spray every 3rd week.
Right, absolutely. And the research that Dr. Shoemaker has done on reversing atrophy of various areas, such as the caudate nucleus, is actually very interesting and exciting, isn't it? So it sounds like, overall, it's a bit of a complex maze. And one thing that people are probably going to need is the help of someone like yourself, who's a physician who's conversant in both stealth infections and mold illness. And would you say that having a physician or a practitioner of some kind who's very familiar with both worlds can help people to get a good integration between the treatment of all of these different factors?
Yeah, I totally agree with you, because this is such a difficult, complicated, set of conditions. And, two gems that I would like to kind of leave people with. One is that as you embark on your treatment, if you're not seeing some improvement every few months as you look back, there's something that you're missing. So just kind of keep that in mind. And for health practitioners that are out there, I have one gem for you. The traditional testing, while it's good and needs to be used, is by no means perfect or comprehensive. And if you can find a good health practitioner that does some form of energy testing that you have worked with for a while, that you've done testing to confirm their work, can be a tremendous asset in helping you to identify all the different things that your patients may have.
Okay, great. And so when you're saying energy medicine, you're meaning things like autonomic response testing or QRA or Zyto testing, or there's a number of different things, different modalities, isn't there? Bioresonance is another one.
Yeah, there's a number of tools out there, and it doesn't really matter which tool you're using. The key is to find a practitioner that is well versed in it and gets good, consistent results for you as a health practitioner, because I've had to go through probably at least 10 to 15 different practitioners before I found a couple of them that I use consistently, where I see them coming up with very good information. And I joke around, they make me look good because they find things that normally most doctors can't find with their usual blood testing. And when we incorporate some of their findings along with what we find on blood testing, we actually see very nice results.
Okay, great. So having a really well knowledgeable practitioner is super important. I also just want to talk about the knowledge side, like for a patient to basically be confident in what they're dealing with and to feel that they understand this area is also super important, right? And so basically, and I mentioned this before, and this is going to be my little plug, I have created an 8-week online course, which is called moldillnessmadesimple.com. And it does predominantly focus on mold illness rather than Lyme disease and stealth infections. However, there is a section that covers those as well. And the big thing that it covers is the difference and understanding the difference between the IDSA and the ILADS approaches to Lyme disease, or the understandings of Lyme disease. And I think that's very important to get your head around. And it'll save you a lot of headache, I guess, in going to various different doctors and getting totally different opinions, is if you understand what the difference in the group opinion is between ILADS and IDSA. And so that's the main thing. It will be expanded in future as for the information that we're presenting on Lyme disease and stealth infections. However, I believe for people who are dealing with this conundrum of whether part of their illness could be Lyme or stealth infection or viruses versus mold illness, I believe this course gives a number of very important skills. And one of those skills is the learning to basically gain awareness around your reactions to water damage buildings. So, and I don't know if you recommend this to your patients, Dr. Patel, but we talk about the use of a mold sabbatical, which is, I guess you could say, is another way of doing a functional test of whether your building is affecting you. So if particularly, let's say you're not in the United States or you don't have access to a physician who can give you the serial C4A test, in this course we talk about how doing a mold sabbatical, so for instance going camping for 5 to 7 days and then returning to your building and learning to pick up the subtle signs that you may be reacting to a water damaged building, that's going to help you to know which component or how much of your illness may be responsible for exposure to a water damaged building. So that's a really important skill. And I believe that if you can develop this awareness and develop the skills of being able to hone into your sense of smell, into your vision, and other subtle signs of a water damaged building, then you're going to be able to work out to which degree mold is contributing to your illness. And that's quite important. Anything you'd like to say about that specifically, Dr. Patel?
Yeah, I think that's an excellent idea. If you can get out of all public buildings, go off, someplace for 4 or 5 days, you will. If you have a mold illness component, you will see some improvements. You could even, take some cholestyramine during that time and see if you see some additional improvements. And then when you stop the cholestyramine and go back, I would expect if you truly have mold illness, you will see a flare-up of your symptoms. And the other thing I just want to support you. I think that you've done an amazing job here with this program. And education, if you're a patient, educating yourself about mold and Lyme is critical. There is so much information, some good, some not so good, on the web. And to have a course like this where you can get some good, reliable solid science and a understanding of a basic foundation of what's involved with mold and Lyme disease can help you move forward in finding a practitioner and working with them.
Great, thank you. And if we could just jump back one slide just for a moment before I go into this little offer, I just want to also explain that we do cover some of the important co-infections as well, particularly babesiosis. And if you have a look on the top left hand portion of this slide, you'll see that we talk about babesiosis and some of the symptoms it specifically causes, such as flu-like symptoms, fevers and chills, night sweats, etc., and give you a bit of an indication as to which testing may be beneficial if you're thinking about babesiosis as being a possibility. It basically down the bottom again, looking at remediation options. So this slide dealt with fogging, gassing, and spraying, and there's a whole bunch of different. If you do basically work out that a significant portion of your illness is due to mold or exposure to water damaged buildings, you're going to need to work yourself through the big question of how to get your building better, or do you need to move? And I believe for that point alone, this course is worth it, because if you make a fundamental error in that step, it is going to cost you a lot of heartache and a lot of money, actually. And some of the really costly mistakes are getting the wrong remediator or getting the wrong mold inspector. Because basically, if you get someone who's not qualified to inspect your building and falsely reassure you, you're going to waste a whole bunch of time. And if you get the wrong remediator who does not know how to remediate your building correctly, that's going to be a real problem, because they can actually do a lot of damage to your building. So in the course, we cover a lot of questions that you can ask to IEPs or indoor environmental professionals, and also to possible remediators, to make sure that they are properly qualified in this area of CIRS to be able to actually give you the level of excellence that you need. So these are some other things that are covered in this course. I really do believe this course is beneficial and worth it. I do believe Dr. Nicola has brought out a specific course if you want to go very, very specifically into all of the different Lyme co-infections. But if you just want an overview of Lyme and also a lot of information about CIRS, and particularly CIRS due to water damaged buildings, this course will help you to feel much more clear and confident. And that's an important thing in moving forward, is to feel a degree of clarity and confidence, because if you're overwhelmed, you're not going to move forward. You're just going to be stuck and paralyzed. And therefore, in some ways, knowledge is power. So we do want to, as a special thing after this webinar, to offer this coupon code, which we've called Beat Stealth. We should have called it Raj 123 or something, but we didn't. We weren't smart at the time. And it's a 25% discount code. So if you go to the course website, which is www.moldillnessmadesimple.com, and go to the sign up area, you can plug in Beat Stealth to get this discount over the next 48 hours. I really, really believe that if you're looking to understand this illness, it will greatly help you. And if you follow the link below, that will allow you to access it. Alrighty, so that finishes my little plug on the course, and now we'd like to take a moment to take some questions and answers if you have some time for that, Dr. Patel.
Absolutely, love to.
Okay, great. So first question is about NeuroQuant. Dr. Patel, does NeuroQuant identify Lyme and co-infections, or just Borrelia? This is something that's actually come up on a number of different Facebook groups and so on. So if it's just Borrelia, is it identifying the bacteria or the biotoxins it produces? So can you please clarify what specifically NeuroQuant is finding?
Yeah, the NeuroQuant parameters that Dr. Shoemaker has developed for Lyme, in my experience, are not sensitive enough. So if you have a NeuroQuant for Lyme and it does not meet the criteria that he has developed, it does not rule out Lyme. I really want to emphasize that. If you have a NeuroQuant that does meet the Lyme criteria, it'll support your diagnosis. The changes that are brought on, I suspect, are primarily from the Lyme bacteria, but I don't have any evidence of that.
Right, it's basically we're talking about inflammatory changes, aren't we? So basically when we're looking at NeuroQuant and we're looking at subtle swelling and subtle shrinkages in different areas of the NeuroQuant, we're talking about changes which are induced by these inflammatory proteins such as TGF-beta1 and MMP9. And the important thing to know is that in a classic Lyme infection, for some reason, it tends to target this right thalamus side of the brain. And that just appears to be an inflammatory pattern that happens with a severe acute Lyme disease. But, you know, often one will find that the classic signs of mold CIRS, which includes shrinkage of the caudate nucleus and swelling of the forebrain parenchyma, those can still be there with a chronic Lyme patient because because they're also getting some degree of mold-related inflammation. So that's really important to be aware of. And the other thing I'll mention quickly is also one can show up with multinuclear atrophy, and I actually find that's possibly a stronger Lyme marker in some ways than the classic Lyme criteria. So, and presumably you've had a number of patients who've shown up with that pattern, which is where 3 or more brain areas are shrunken or atrophied, and that suggests. And Dr. Shoemaker says we need to look for other illnesses other than mold, and it actually was correlated in his studies with Lyme disease much more strongly than mold. So that would be another indicator that Lyme could be affecting you if you have multinuclear atrophy. Any thoughts on that, Dr. Patel?
Yeah, I mean, Lyme is very similar to syphilis from back in the old days that caused a lot of dementia when it was advanced. And we do find multinuclear atrophy in many of our Lyme patients that are more severely ill or who've been ill for a long period of time.
Okay,
and
great.
The good news is that we can reverse it with the VIP.
Okay, excellent. And so VIP can also be a useful tool for chronic Lyme disease sufferers.
Absolutely.
Okay, great. So next question is, I suspect it's different for each patient, but are there preferred Byron White formulas, or let's say any herbal formulas, that you tend to use specifically for Borrelia, Bartonella, or Babesia? Now that's probably a 5-hour lecture, but I don't know if there's anything you want to mention specifically.
Yeah, I'll just, real quick. AL complex is a good broad spectrum Byron White formula that will target both the Lyme and the Ehrlichia and Anaplasma in most cases. It'll target different forms of Borrelia, including Borrelia Miyamoto. They also have a separate formula for Ehrlichia called A-Bio, A-BIO. I'll just tell you real quickly, my approach to treating these infections once the inflammation has been addressed is to go with micro doses. And I'm talking about really low doses and to ramp up very slowly. I find patients tolerate it better because the herxes are manageable and they actually tend to get well much faster.
Okay, great. That's really, really important information. Thank you. How many patients who are strictly dealing with Lyme disease, not mold, have you find have a positive MARCoNS test?
Most of them do. MARCoNS is multiple antibiotic resistant staph in the nasal passages. It is not an infection, but it's colonization. And what MARCoNS does is it produces substances that depletes or breaks down the circulating MSH. And when you have low MSH, you become more predisposed. Okay, it's a sign of hypothalamic compromise. And it's equally common in our mold patients and our Lyme patients.
Okay, great. So that's really important. And by, by association, it's probably important to realize that the implication is most chronic Lyme patients have low MSH. And this is really important to know for the ILADS doctors as well, particularly just to be aware of this phenomenon of low MSH and everything that goes along with it in chronic Lyme disease patients. Okay, next question is, I've seen so many live blood screening forums suggesting we can see spirochaetes and Lyme bacteria under the microscopes. Are you aware if this is possible?
I don't use live blood analysis in my practice, so I really I would have a hard time being able to comment on how accurate that kind of testing is.
Okay, and which test do you find the most useful to diagnose Babesia?
Babesia will typically start with the antibody testing, IgG, IgM for Babesia microti and Babesia dunconi. If I'm strongly suspecting based on symptoms that they have it, but it's not showing up there, we'll go to a Babesia fish test. And many times I will treat them with an herbal approach if the blood tests are not showing positive, if they have some strong symptoms of air hunger and night sweats. And what you'll inevitably notice is that those symptoms start to go away as you ramp up on the amount of the herbs that you are having them take. Yeah.
Okay, great. And are you familiar with Dr. Alan McDonald's recent findings of nematodes with Borrelia endosymbionts, found in the brains of those with MS? And could this be why many suffer the symptoms of Lyme without testing positive with antibody testing, i.e. the bacteria could be hiding within parasites, etc.? Also, Dr. Klinghardt argues that parasites must be treated before anything else. And so, second question is, do you find treating parasites is essential? And if so, how and when does this happen?
Yeah, absolutely. I think that this is fascinating research. It kind of supports what we've clinically been seeing in our practice, that parasites are a huge issue. And it's challenging because the traditional stool testing that's available is very, very inadequate. And even labs that specialize in parasite testing, I find that they are successful at identifying protozoan parasites. But when it comes to nematodes and other types of worms, we just don't see those stool tests showing up positive. So sometimes patients will tell us that they're seeing it in their stool. Sometimes on energy testing, whether it's ART or Zyto or something along those lines, they will find parasites. And if we have any suspicion, we will go ahead and treat the parasites pretty aggressively. And I find that this really opens the door to success with the other infections.
Okay, great. And now back to NeuroQuant again. There seems to be a bit of a fascination with NeuroQuant today. Will the brain atrophy and inflammation representative of Lyme disease reverse once the Borrelia bacteria is treated, i.e. with antibiotics, I presume they mean? Or will this pattern remain until the associated biotoxins are bound and eliminated? How long before one can expect NeuroQuant to reflect the eradication or control of Lyme disease?
In my experience, this hypothalamic damage to the brain that results in low levels of MSH, and that we typically see these other brain changes, do not reverse when you get rid of the Lyme bacteria and the co-infections. You have to go back in and repair the damage that they've left behind. And that involves using VIP, vasoactive intestinal peptide, which will then not only regain the function of the hypothalamus, but it will also reverse these changes on MRI.
Okay, great. And is the treatment GcMAF something that you recommend for patients with chronic viral infections?
I find GcMAF to be a very harsh treatment for viruses. It can cause a tremendous amount of inflammation. And my approach with viruses, what I have found is that you need a soft touch rather than a hard touch. You can use prescription antivirals. You can use some of the herbal formulations. Beyond Balance has a wonderful one of my favorites called IMNV2. Byron White has something called AEBH6 that works well. But again, we're looking at very micro doses and ramping up very slowly, typically up to maybe 2 or 3 drops twice a day. And this will typically bring the viral activity down very nicely, bring the nagalase numbers down without having a lot of inflammation. The other piece that I just want to bring up real quickly is if you've done your methylation and you have a VDR, vitamin D receptor mutation, on either TAQ or BSM. If you're heterozygous, or especially if you're homozygous, where you have two mutations, doing narrowband ultraviolet B light therapy can be extremely useful at reducing viral activity and allowing vitamin D receptor function to be reactivated. Typically, we start with something like this at very low amounts, typically 2 to 3 seconds, going up by 1 second every 2 weeks, up to typically between 10 to 15 seconds every 4 days or 2 times a week. And what we find this will do is this will reduce nagalase levels, reduce viral activity, open up the methylation cycle so your body starts detoxing a little bit better. And I've found it to be one of the most useful tools in combating chronic viruses and getting vitamin D levels back up.
Okay, great. And if people want to find out more about that, is there any particular information or websites you could point them to?
Yeah, unfortunately, there's not a lot of websites that I know of. This is something that I've stumbled upon over the last few years. And the company we use is solarcsystems.com, SOLARC systems.com. They have a unit that roughly, if I remember right, goes for about $1,400. It has 3 light bulbs. And like I said, if you're going to do this, go very slowly, 2 or 3 seconds. You break up the body into 5 sections, 5 quadrants. You treat 1 quadrant once every 4 days. So takes you about 2.5 weeks to go through all 5 sections of the body. And your target is to get up to about maybe 10 to 15 seconds twice a week, and that's your maintenance. And if you do nagalase testing before and after, we consistently see these nagalase numbers come down.
Okay, great. And is that something that's been studied in the literature so far, or is the study still to come? Yeah,
I did a PubMed search about 6 to 8 months ago on this topic, and there are probably about 10 to 15 articles that I came across that noted the benefits of narrowband ultraviolet B light therapy in supporting methylation pathway, in reducing incidence of eczema. Psoriasis is a huge application, traditionally. It also activates vitamin D receptors. It activates macrophages. So there's a lot of very good information supporting its use.
Okay, great. This is new information for me as well, so thank you. Hyperthermia, do you consider that in patients who have refractory chronic Lyme disease, that the addition of hyperthermia to their other regime, whether that be antibiotics or herbs or other things, could be of benefit?
I don't have a lot of personal experience with hyperthermia. What little I've seen from some of my patients, I find that, yes, it does help, but it's rarely adequate in and of itself to eradicate the Lyme bacteria completely. Yeah. My suspicion for whoever is asking that question is that the traditional herbs have probably stopped working because you have a lot of uncontrolled inflammation, and that your use of the herbs in the past probably worked maybe for a week or 2, and then they stopped working. And this is a typical pattern that we see when people get sensitized to the herbal formulations and they stop working. The trick is to reduce the inflammation, find out what's causing it, go through some kind of an energetic way to desensitize, and then you'll find that the herbs start working again.
Yeah, right. And there is a study from Reisinger et al., which I've reviewed recently from 1997, which showed that hyperthermia at levels around 39 or 40 degrees, they made it around, it allowed the effectiveness of intravenous ceftriaxone and penicillin to be increased by about 3 to 4 times, but it did not eradicate the Borrelia on its own. So it seemed to be a sensitizer, if you like, that allows other therapies to work. So I guess at this point it's unknown whether it does the same thing for herbal therapy or not, but there's every chance that it could.
Yeah, I would suspect so.
Okay, next question. I tested positive recently for Chlamydia pneumoniae. Could this affect the gut specifically and also cause anxiety, or should I be looking for other causes?
My experience with Chlamydia pneumonia is that it tends to cause a lot of inflammation, fatigue, Sometimes it will cause some lung symptoms. I have not seen a lot of GI symptoms short of some of the inflammation and the leaky gut. If you're having a lot of anxiety, Bartonella would be my first area that I would look into.
Agree. And pyroluria, I would also add to that as something to look into. Heavy metals, do you recommend looking into having diagnostics for heavy metal toxicity if one has a chronic illness that one is not recovering from? And do you consider treatment to be important?
You know, bottom line is that we've all got a significant load of heavy metals in our body. Just from living life here on this planet. Just because you have a load of heavy metals, I mean, there are a number of challenge tests that you can do with chelators where you do a urine collection before and after, and almost everyone will test very high on the post-chelation urine test. That does not mean that it is impacting your recovery. And this is where it gets a little hard to try to figure out whether chelation is necessary or not. In my experience, I'd say probably 9 times out of 10, you don't need to do anything about heavy metals. Every once in a while, we do find patients that are being stressed when it shows up on energetic testing. And in those individuals, we will do a little bit of work on the heavy metals to help kind of open the door for the immune system to work more effectively. But most of the times, I find that it's not a huge issue.
Okay, great. And it seems that in some patients, the apolipoprotein, they've got a gene mutation with the apolipoprotein E. And for instance, if they have a 4 in there, they have got like a 3-4 genotype or a 4-4 genotype. We know those patients are particularly prone to getting Alzheimer's disease, for instance, and that they have a decreased ability to cope with heavy metals in the brain. So would you say perhaps in those patients that heavy metals might take a greater importance?
Yes, absolutely.
Okay, great. And then finally, is there any particular reason that you leave MARCoNS treatment towards the end of your protocol?
That's a very good question. MARCoNS treatment, as I think most doctors have found out, is extremely difficult. It's not unusual to have to go through it 2 or 3 times, and even then the success rate is not optimal. What I find is that if I've addressed the inflammation and all the other chronic infections are gone, the success rate tends to be a lot higher. You know, dental MARCoNS was presented by Dr. Mary Ackerley about a year and a half ago at the Mold Conference. And I think that if you have dental issues, cavitations, root canals, that may be something that may need to be addressed before you proceed with MARCoNS treatment.
Great. Thank you, Dr. Patel. And I really hope this webinar has been really beneficial for everyone today and you know, shed a bit more light into this complex situation of trying to tease apart whether your illness could be due to mold or Lyme disease or other stealth infections. So I'd like to say a big thank you to Dr. Raj Patel for joining me today and sharing really these innovative approaches to dealing with chronic illness that you've developed. So thank you very much, Raj. I've learned a lot myself. So thanks so much. And also a big thank you to Caleb Rudd for his assistance with content and technical support. So thanks for joining us, everyone. I really hope you have gained a lot from this webinar and have a beautiful rest of your day. And again, just that final plug for the Mold Illness Made Simple course where we have a discount code for the next 48 hours. Thanks very much.